Hello and good morning good afternoon to those of us here in the US, and good evening if we are being joined by anyone in Nigeria or Ghana today. Welcome to our live stream event, Mind Matters Beyond Borders. My name is Dr. Heidi Burns. I'm here with the Michigan Medicine Department of Psychiatry. I am an assistant professor in psychiatry who specializes in areas including global mental health and emergency psychiatry. Today, I am joined by Dr. Frances Adiukwu, who is a trained child and adolescent neuropsychiatrist living and practicing in Nigeria in the Department of Mental Health at the University of Port Harcourt. Dr. Adiukwu's research interests include global mental health, biological markers of severe mental health disorders, and early intervention in psychosis. Dr. Adiukwu is a visiting scholar for the University of Michigan's African Presidential Scholars Program and has spent her time here in Ann Arbor working with the Heinz C. Proctor Bipolar Research Program. Before we start, a few housekeeping items. If you're watching this live, you can submit questions at any time for our panel to discuss during our Q&A portion. Questions can be submitted by commenting on the video of whatever platform you're watching on. But please note that if your name or profile name will be visible to others participating. If you prefer more anonymously, then send private messages to us via the social channel that you're viewing this on. If you can't stay for the whole chat or want to share this recording with a friend, a video of the chat in its entirety will be available to our Michigan Medicine YouTube channel. Now I'd like to turn it over to my guest here, Dr. Frances Adiukwu, who will speak on her experiences practicing psychiatry in Nigeria and her time here at Michigan Medicine with the Proctor program.
Good afternoon to those of us in the US, and to those of us back home, good evening. My name is Dr. Frances Adiukwu. I am a psychiatrist living, working, and practicing in Nigeria. I am a lecturer at the University of Port Harcourt in the Department of Mental Health. Also, I work with the Department of Neuropsychiatry at the University of Port Harcourt Teaching Hospital. My areas of clinical work have been around child and adolescent psychiatry. However, I think my interest has grown in mood disorders. I think it started off from working with the adolescents and noticing the early onset of illnesses, and it just sort of grew into mood disorders and the peculiarities and the difficulties, and my research interest. And going forward, my clinical work would center and focus around mood disorders, bipolar disorder in particular. I have, in my career, I've been fortunate to be a recipient of certain seed funds and exposures and connections with the World Psychiatry Association, the section for genetics in psychiatry, which was the I'll say the catalyst that led me to Michigan, because that was where I connected with Professor Melvin McGinnis, where we started having discussions on growing a cohort of bipolar patients back home. And that led to discussions on me coming over, and then I applied for the Presidential Scholar Program, which I got, and allowed me to come here and understudy, take trainings, gain experiences, and also share my experiences from back home with people here. And I think that has been a great experience for me, not just the fact that I get to, work with people in the Proctor Bipolar Program and to gain from their wealth of experience, to share the enormous resources that's available to them, but also brought on the conversations that have led to this webinar. And I think one of the things is that, the discrepancies that does exist with psychiatric practice and research back home and what's, is going on here. And I remember having a conversation about how difficult it was for us to actually have research groups back home. And I remember, when I had tried, this was in about 2020, when I had tried connecting with other psychiatrists around West Africa, and I had so much difficulty. I remember particularly trying to connect with Ghana. And then it was quite difficult because I couldn't reach anyone. I tried different mediums, tried social media, and I just couldn't. So, it just got me thinking that, there's so much we have to offer, but then the connections and the relationships and the opportunities to work with together, is sparse. So I hope that this webinar would sort of help us bridge these gaps that we have and, talk more on it and actually put things into place that can improve what's currently happening.
Thank you, Frances. I think that definitely echoes with me. One of the really remarkable things that I found when I was in Ghana is that I was surrounded by a bunch of colleagues who had been advocating so hard for mental health in their country and had been working so hard to, create research opportunities, and the connection and the system sort of connections was one of the big barriers that they were feeling as well. And some of the frustration, was really palpable about having a lot of, energy and ideas, but having trouble connecting with others. And so I agree. I hope this is just one more opportunity to find ways to connect people.
Yeah, definitely. Because, if you look out, I know that, yes, we have loads of difficulties back home. We have limited resources and we can't say enough of the mental health gap that does exist. But there are certain things, like you said, the energy and the passion to do this thing that we're doing, in spite of the stigma, in spite of the difficulties, the extra measures we take to provide mental health care to people. And I think if we have opportunities to improve on that, to showcase what we actually do, and the differences we actually make in the lives of people we come across, I think that's something that should be, put there in the forefront,
Absolutely. I think I'd like to take a minute to sort of talk a little bit about some of the, some of the statistics, some of the things to kind of bring people in, because I think you and I have these personal experiences, and we can talk a little bit more about kind of what those experiences on day-to-day, life practicing psychiatry and low resource settings is like. But I think, the first time I met you, I think we connected on that idea that there's actually, I think a lot of beautiful, wonderful things happening too, and that sometimes gets lost in that discussion about the lack of resources. So, I think for some people who are watching this, they may know a lot about global mental health, and some others, this may be kind of an introductory webinar for them. But, mental and substance use disorders are now the leading cause of disability in the world. And I think that, if you look on like World Health Organization websites, you'll see a lot of statistics talking about that mental health gap. And that, a very, very high percentage of people are in need of mental health care and are not able to access it. And so a lot of, I think, the work that is done in lower and middle income countries related to psychiatry is related to capacity building and trying to create opportunities for people to connect to care, which I think is really exciting work. And, personally, I had an opportunity to be a part of a partnership branch that came through the University of Michigan's Department of Psychiatry, where we connected with a hospital system in Ghana in 2017 and created this relationship to try to build up workforce capacity and improve access to treatment. And had an opportunity in 2017 to go. I spent a month during my child and adolescent fellowship time, kind of doing a listening tour and also doing education related to the subspecialty of child and adolescent psychiatry. And Frances, you and I talked a little bit about, one of the areas that is really ripe for transition and movement is related to training. And training opportunities within Nigeria and Ghana. And we talked a little bit about there being some differences. And Interestingly, you can get your general psychiatry residency done in Ghana, but there's some limitations about the training programs that you have. And so some of these, connections like this development program that I was a part of was really trying to work on creating more training opportunities and making, subspecialty training in particular available to more people in Ghana. Because currently what they end up doing a lot of times is, for example, for child and adolescent psychiatry, they'll end up actually going to Nigeria to do training programs there. And they have this ability to sort of have an exchange. You can go, in other West African countries, you can kind of go in between and do some of your training program, or they may go to places like Canada or the UK or Ireland and have training programs for addiction, psychiatry, or geriatrics, or child and adolescent, in order to get that subspecialty training. But currently in Ghana, they're still developing those programs internally and don't have that opportunity. I was wondering a little bit more what it's like for that pathway in Nigeria, and if you find that people often are attracted to subspecialty programs and they're going in and having lots of opportunities, or where are the limitations there with training programs?
Okay, right. So, back home in Nigeria, we have our training institutions, the postgraduate training. So we end up getting a fellowship or training in general psychiatry. And then I think in the past, it used to be sub-specializations based on experience, and any training you can go and get outside, publications and the rest of them. But now they are getting more structured programs for subspecialty trainings. And I think we are lucky in the fact that we're able to have some of those training programs available. But then we don't have, I know we have for substance abuse, geriatrics, child and adolescent, but then psychiatry is more than those three. There are quite a lot of subspecialties and subspecialty trainings, which are really not available. And then if you look at if you're not breaking it down to, let's say child and adolescent, for example, we know that majority of mental health conditions begin in that age bracket with early adulthood, and then we have very few of those specialties. And then, of course, you know that the mental health gap in that area is huge. I mean, to put the mental health gap into context, I think in about, was it in 2015, 2016, when they were saying it was about 2 to 3 people that actually require mental health care out of 10 that would receive some form of mental health care. But then if you're considering it now with the current brain drain and the growing population, that figure is coming down. So it means that maybe 1 in 10 persons will have access to some form of mental health care. And then when we now talk about subspecialty care, it's actually further reduced. As it stands now, looking at the amount of people that are getting some form of training. I have looked at the figures, and in Nigeria, this is unofficial, we have about 512 psychiatrists. That's those who are actively practicing, those that are retired, those that have migrated out. It's about that figure. And I just got that from looking at one of the groups that contains all psychiatrists. And then when we come into those who are in the early phases of their career, so these are the people that can be trained and that can have, access to, because their careers are just starting. So the early career group, we have about 300. And then this, of course, has to do with, this is everybody that we know. Those who are migrating out are included. Majority are males, very few females. So if we have about 300 people, which is the future of psychiatry in Nigeria, attending to 200 million people, if you break, I mean, the disparity is just too much. And then people are migrating now because I think when they go for trainings and they see opportunities out there, they stay. So it'd be nice if we had, some form of training, career opportunities that can actually encourage people to stay back and put back things that they are learning into the community that that's trained them or that they're working with. So, so these are some of the difficulties that we have. And the thing is that if you're looking at West Africa, Nigeria has it better than most West African countries. Because I remember trying to search in Ghana and I saw that we actually have maybe 10 times more psychiatrists than Ghana does. And so And I keep telling people that I really cannot talk for the whole of Africa. I can only speak for Nigeria, where I work. So I don't even understand the difficulties, or I cannot comprehend the difficulties that psychiatrists in Ghana would have to face in terms of providing care and having to deal with not just providing care to a population that is growing. Mental health care is ranked high up there in terms of global healthcare impact, but then also getting people to want to access the care that's available. That's another difficulty that we have to face. So we are constantly advocating for mental health care, constantly fighting against stigma, stigma in the community, stigma in institutions, towards people with mental health conditions, towards people that manage mental health conditions as well. So these are some of the uphill battles that we have to face, that we fight every day, just to make it better back home.
Absolutely. And I think, I'm lucky to have met some amazing people doing the work that I had done. I had spent 3 years in country in Ghana, working with Komfo Anoche Teaching Hospital in Kumasi, which is kind of the second city in Ghana. And, my direct mentor, Dr. Ruth Osu Antri, was actually, she has been the past president of the Ghana Psychiatric Association. So she, there's the people that I had the luck to sort of be around were really the people driving change in Ghana. And I think, recently had a conversation with her to sort of touch base about what is happening right now in Ghana. And she, make sure that I had my statistics up to date too. And, Ghana is about 32 million people or so, and they have about 73 practicing psychiatrists right now. Which is a significant increase, even from the time when I was there in 2018. I think they had maybe 25 or so.
25. Because I remember that was when I had looked and I couldn't really. That was, I think for me then that was just mind blowing. I was like, then we had about 250, and then I was like, oh my. I mean, we are complaining that we're not enough, but then, so that was really mind blowing for me. Yeah, so that increase is great.
Population is I believe, the fastest growing population in the world.
Yeah.
You have this sort of constantly growing environment where you're going to have to give access to more and more and more people. So that's got to be quite a daunting task to think about. And like you said, there's lots of barriers for retention. Stigma barriers, things like that. But I also wanted to make sure, we have discussed that there are some things about West African cultures too, though, that are really remarkable. And I think, one of my big questions for you is kind of what could Western psychiatry learn from the Nigerian and Ghanaian systems? What do you think, is something that they have going on that's really, truly intrinsically theirs that makes psychiatry different and improves it?
Okay, so I think one of the things, which is one of the research I'm doing here, is looking at something that is very, I would say very sacred to us back home, which is the family structure. Our family structure is it's not a nuclear family structure. It's not just it's not just the extended family structure. It's like the community family structure or something like that, where everybody takes care of everybody. And so because I know for my center where I work, one of the things that we have been able to do, and I think most centers do it, is the incorporation of family into the care of people that have mental health disorders. And when we say incorporation, we mean every step of the way. So for us back home, what we noticed was that, decisions cannot be made about assessing treatment without having family members agree to that discussion. So the only way we knew, or what we realized, was that to get people to assess mental health care and to destigmatize it was to get the families really integrated in the care of people with mental health disorders. And so this starts off from just the outpatient care. Let's start with outpatient care, for example. Patients come into the clinic and they come with a family member. And so while you are taking your history, the family member is there. While you are making a diagnosis, they are there. While they are formulating it and explaining it to the patient and the relatives, so that they understand that, yes, because this is Western medicine, but we have to take in the cultural context of where we are, which is Nigeria. And so we have to take into account the spirituality, which is very ripe in our country. We have to take into account that that most mental health conditions have a spiritual formulation in terms of etiology. That has to be taken into account. And once everything is sort of put into the picture and explained to the family member that, look, we don't argue in terms of what the etiology is, because truthfully, we don't really know. Western medicine hasn't figured out etiology of mental illnesses. So we can't say you are wrong, we are right. But what we say is, this is what we can do to help improve the situation. And once the family members are keyed into it, then treatment is better. So they are involved in medication decisions, they're involved in psychotherapy, they're involved in occupational therapy, they're involved in nursing care for inpatients. One thing that we do is that when a patient is admitted for inpatient care, for the first week, if a family member wants to stay in hospital with them, it's encouraged. We actually encourage it because it helps the patient feel less in an institution and more in the hospital. So, in doing so, we found out that we have better retention rate in terms of care. Once a family member understands mental illness and that it can be treated, there's less stigma. They're able to tell other people. So in doing so, we actually increase the number of people that access care with us. So we increase the people that access care. We realize that people are more likely to adhere when the whole community is involved in the care of the patient. And I think this, for me, when I noticed that being here, that's not the case. This isn't the approach. But we found that this actually helps back home. It helps enormously. And so most mental health facilities that I know, incorporate this. And I don't know if that's the same in Ghana, but it's something that we do, and it makes our jobs easier, and then we've sort of become part of the family of the patient. So, a patient that has been stable would come back into the hospital to visit the nurses, the doctors, to speak to other patients. They become advocates of mental health, because they have the lived experience. They've seen the improvements. So I think this is something that can be imbibed here, and I feel it can help.
I 100% agree. And I think there's a lot of similarity to what I had seen in Ghana. And I think a lot of beauty in the fact that you weren't alone with your mental illness. I think it can be, it can be extremely stigmatizing. I think sometimes in the beginning of that journey where you have a family member who has mental illness can start out somewhat rocky, and families sometimes would, hide that person or keep really close tabs on them, but the family was still taking care and making sure that person was provided for and trying to deal with that. And I noticed that in Ghana, religion and spirituality is also extremely important. And Ghana has said to have been one of the most religious countries in the world. And I think there is a real importance on spirituality as well as the family unit. And so, families are seeking help for their loved one and will oftentimes go through, a traditional healer or a faith-based group before they come to the hospital system. Sometimes once those things have kind of not worked out for them, they continue to sort of help their family member try to find the right treatment, and they would end up to clinic and being seen by psychiatry. And I think the beautiful thing is the commitment that the families had to trying to help their loved one, caring for them, like you said, in the hospital, coming to their appointments with them. They really enhanced treatment outcomes for the patient. And if you had the buy-in, especially related to some hierarchies within families, if you had the buy-in of the right first, you're going to go far, and that patient's going to be very well treated and cared for. So I think the emotional support they get, the financial and living support that they get by having the family involved is truly remarkable, and is something we could definitely learn a lot from.
Yeah, definitely. So I agree. And then and I think that that approach, and I know that global mental health is really shifting in the idea that, you know, global mental health used to be, okay, there's a disparity, how do we come and fix it? But it's becoming more of, okay, there is a disparity, how do we understand the disparity and learn from it? And that's the only way we can improve it. So it used to be that let's come in and wipe out the spiritual etiology basis of mental illness in maybe in Africa, lower middle income countries, and explain to them the scientific basis behind it. But that's shifting, because if in doing that, there's always going to be the skepticism in terms of, you know, why are these people trying to impose this thing on us? But in understanding the culture of the people, understanding the society, the way of life, I think that's the only way you can actually make an impact in that society. And I think we had talked about the need for like a bi-directional, you know, exchange programs, because the whole idea now is that we should collaborate with each other. The West should collaborate with the global South and all of that. So Africa should collaborate with people in the US. But how do you do that collaboration if we really don't understand each other's societies, each other's cultures, each other's way of life? So we really need to do that. We need to do that and have that understanding. And the only way to do it is actually to have the lived experience of being in that area and understanding the differences and understanding why people see mental illness the way they do, and how we can, you know, what we can give and what you can give to sort of improve both, you know, societies. Because when we are talking about disparities in health, in mental health care, even within the US, there are disparities in mental health care. So and because the world is a global village now and people are migrating, so how do psychiatrists in the US attend to people of African origin when they have a mental health problem if they don't really understand the culture behind it? You know, I had this story that there was a time with my residents back home where we had a patient who came in. I think he was manic, but in his delusions, he said he was a deity and could speak to animals, and so with treatment he got well, but he held on to the belief that he was a deity and could speak to birds. And my residents were saying, "Oh, he's not well. Let's increase the antipsychotic." And I was like, "I think he's okay." You know, but then by the time the family members came in for the ward round, they said, "Oh, he's fine. He's actually a deity. He has done the initiation right. He actually has the gifts to speak to animals." And then I was like, "Okay, let's," you know. So if someone says so here, all we're going to do is just keep increasing the antipsychotics and knocking off the person, rather than actually understanding the cultural, you know, belief, because that's what psychiatry is. You know, everything has to do with, even when you define what is a delusion, it has to do with the person's cultural, religious, you know, background. So how do we then treat people who are migrating from different countries if we don't have an idea of what's going on, what their culture is? Yeah.
I think that's beautifully put, and a really good example. I think even just thinking about some of the language that's used in Ghana, you know, the word prophet is something that is, you know, it is used daily for people, certain people who are, you know, religious leaders. And
yeah,
I think in the United States, using that, it would draw some attention, like perhaps this person is quite grandiose, and, you know, we're interpreting them very, very differently in this space, and, you know, with the cultural context that we know in the US versus in other countries. So
yeah,
it's a great point, you know, the point about exposure. And I think it's really remarkable sometimes to watch people from the West go over to other countries and experience things for the first time, and very humbling as a person who, you know, was trying to sort of embark on a research project myself. You know, I spent the entire first year I was in Ghana really just doing research that was about perceptions. You know, really just learning what people felt, what people think, how they reacted to, you know, the topic was suicide, and, you know, just understanding that, and in its small little bubble, one hospital system in one city in this giant country, you know, and you knew you only had a tiny little view about what that was coming from the outside. Yeah. So I think it was a really humbling experience to see that, and then to, you know, I spent the second year looking at validating a screening tool for that exact sort of situation, that area. And I think the more people come and learn about other places, they would see that, the real goal would be to have the people who know the culture be the ones who are doing that research and doing that work.
Exactly.
And I think some of the questions that are coming in are about something like this. What advice do you have for aspiring physicians or nurses or social workers, people who are in the mental health world, either in West Africa or in the US? What are the things that we can do to sort of help them with shortages of providers? And I think at first glance, you might say, well, you need to increase the numbers. So, should we be doing things where you can have exchange programs for people doing actual work? But there's a lot to be missed if somebody comes from another culture and tries to practice their form of medicine in a completely different context. And it seems more that we should be kind of working on capacity building and allowing for resources and programming to be developed by the people who know their patient population best.
Yeah, definitely. So I agree, because that was actually the next thing I was hoping that we'll talk about. So if you're looking at in terms of the research outcome from Africa. So research outcome from Africa is mainly from 3 countries: Nigeria, South Africa, and Kenya. And that makes up about 52% of all mental health research outcomes, right? This is from a study in the past, maybe it's increased now, I think it was about 2015. So, but then, and that figure has increased by 200% if you're comparing it to year 2000. But that only makes up about 1.3% of all global health research. So if Africa is bringing out 1.3% of all global health research, 2.5% of all clinical research comes out of Africa, and most likely from these same countries. And we know that the differences, the cultural differences, the societal differences, the genetic differences in people from Northern Africa, Western Africa, Southern Africa is enormous. So if we are producing a minute percent of research, and then we are saying that 99% is coming from the Western world, and then the findings from that research is being imposed on Africa. And so you are saying that these medications that we are tested in predominantly Caucasian population, these research findings on outcomes for maybe a particular type of therapy in terms of psychotherapy, in this population should be used in in a different society, different culture. And then at the end of the day, when you look at even the clinical guidelines, there are very few, if at all, African researchers in those guidelines as authors or as contributing authors or research. And then, but we are meant to apply those guidelines to our own cultural setting, our own situations, our society, our religious background, everything. I feel that is a disparity. That's something that we should look at, and we have to improve that. And the only way we can improve that is actually having the research being done by Africans in Africa. And we know we don't have the resources. We know where the resources are. So how does this collaboration work? We can't do the helicopter style collaborations. They don't work, because it's the same thing. You're designing a method in a country that doesn't understand the cultural background of another country. For example, I'm sure you have this experience in Ghana, asking somebody to give maybe 10 mils of blood, just 10 mils of blood. If it's for a laboratory investigation, they would give it because you're going to give them the results and they know what's happening. But saying that, give me 10 mils of your biological sample, because you want to do something, you won't know what the result is going to be. It has nothing to do with you. I can guarantee you that you're going to have very poor patient participation if you're doing that kind of a research. But if you understood the culture, you would understand that blood is sacred. It's sacred. And so you might be better off if it's genetic material, do a saliva swab. So these are the little things, these are the little nuances that we need to understand when we need to improve research outcome from, Africa, whether it's West, South, East, or Northern Africa. We need to actually understand that particular culture. And the only way to do it is to have those researchers in that culture contribute actively, be at the table when it comes to designing these studies.
Yeah, I think it's a great point. It's I think the other thing that strikes me is again the passion and the interest of the people who work day in day out in their own country, and want to help their own country to find more answers, and do these research studies. And I think you will, from my experience in many different countries, and particularly in Ghana, there's a lot of passion and a lot of interest in solving some of these problems, and trying to find ways to increase opportunity, give resources in some way, or help people to advocate for their own governments and systems to create access is I think one of the best areas that people could help with. So sort of advocacy and education and things like that. What about if we talk a little bit about some of those systems? I think some interesting things that people are asking about in the questions are things like, how do people pay for their care? Is there health insurance? How do these systems kind of operate and work? Because we've talked a little bit about some of the barriers that we, as scientists and clinicians, that we have. But from a patient standpoint, kind of what do these systems look like in Nigeria and Ghana? And I can speak briefly to the idea that, Ghana has had a lot of evolution and change related to psychiatry, and essentially kind of started its journey with psychiatry in the 1950s, and has had a lot of change in laws that were sort of held over from periods of colonialism. Many laws that were in place related to mental health were laws that were from British colonial times that sort of kind of hung around. And there was a very big mental health act that came out in 2012 in Ghana, where they essentially established protections for people with mental illness. And this was a huge moment for Ghana's mental health system and changing the way that people were thinking about mental health. They also stipulated that mental health should be provided, at no cost, and that these patients really should be given dignity and appropriate care. But unfortunately, barriers related to financing that law have kept things from moving forward a lot. But there are significant changes in the way that they are currently doing their health insurance. They have national health insurance, and they've now started to include certain diagnoses in order to get them covered. So things like depression, bipolar disorder, anxiety, those are now included within, the sort of typical medical insurance that you might get, which is a huge, breakthrough for normalizing the idea of mental illness and having it covered by your health insurance. And we've also seen just this year in March, they actually decriminalized suicide. So that was another thing that had kind of hung on for quite some time, since colonial times, that the criminalization of suicide. So if you had an attempt and lived through that, there would be repercussions legally from that. So in March of this year, psychiatrists and mental health advocates had pushed for a long time to decriminalize that, and that occurred in 2023. And I'm kind of wondering if you've seen sort of different changes or evolution over the years that you've been in psychiatry with Nigeria as well.
Yes. Okay. So I think similar to Ghana, we had a mental health act that was, handed down from colonial times, which was very archaic, very crude, very had a lot of human rights abuses in it. And so the Association of Psychiatrists in Nigeria worked so hard for years campaigning to have this reviewed. And luckily for us, I think it was early this year, late last year, we had a new mental health act. And so now it's implementing the act and getting policies and having mental health care. I think one of the good things is that substance use has now been recognized as a mental health disorder. Suicide is a mental health problem. And so the death penalty, or sorry, not death penalty, the criminal, it used to be seen as well as a criminal act. And so that has been taken away. And this didn't come easy. It took years of campaigning, years of, getting the right people to speak on this. And I give kudos to the Association of Psychiatrists in Nigeria. They fought and fought and fought until this was achieved. Now, but then it's implementing it now. That's the next stage that we are in. And of course, we know that's going to be difficult, but at least we have a step, we're in this, we are in the right direction. Then coming to care for payment for mental health disorders. So Nigeria runs, we have both public health system and private health system. So the public health system, healthcare is subsidized to a certain degree. So it's subsidized in terms of how much you pay to see your, the specialist or the doctor. That's highly subsidized, and it's quite affordable, although whatever is subsidized to is paid out of pocket, but it is, reasonably affordable. And then medications that are on the essential drug list tend to be subsidized and cheap. Now, when we're talking about the medications for mental health disorders on the essential drug list, these are first generation medications, the ones with loads of side effects. And I think one of the crippling thing about it was when I looked at the updated version was that even though psychiatry was put number 22 out of 26 specialties, the medications that were put for adult psychiatry were the same things for child and adolescent psychiatry. There's no difference for the conditions. And I can only imagine if these were really being prescribed. So, but when we have to prescribe the newer medications, they're more expensive, it's out of pocket, it's really not that affordable to majority of the population, even though they are much cheaper from the government facilities as compared to private owned facilities, it's still expensive because the drug companies have to make their money. So it's still very expensive. But when it comes to infectious diseases, the government takes the step further and they would actually subsidize the newer medications. Sometimes it's at zero cost. So if that kind of preference was also given to mental health, knowing the disease burden, knowing the fact that if you look at the fact that it occurs, the onset is in the youth, and this is the future. At least if we use that alone, then we know we can reduce, if we reduce the cost of medications, that would go a long way as well. So there are progresses being made. There are still difficulties that we have in terms of people accessing mental health care. Of course, we've talked about the fact that there are very few specialists. We know that we are advocating for mental health services to be available at the primary healthcare and community level. They are not. We are really pushing for it. Right now, majority of mental health care are at specialized mental health facilities, teaching hospitals, some general hospitals, but not all. And so it means that people who have mental health disorders need to find a city where there is this, services available. So, trying to improve that, I think that's another big task that we have to do to get mental health care into the communities. That would also help with the stigma. So we need to train people, even train community health workers to identify mental health disorders, identify, refer for now because we don't have those services. But at least follow up the patients that we have seen in the community level. These are some of the things that we know we need to do, which we are advocating and working towards so that we can improve the healthcare access for patients, people, while we work with the government to see how much they can subsidize our medication.
So it sounds like, access to providers, access to care, access to the right kind of medication. And then, a big part of it, which I echoed a lot in Ghana too, was the financial burden of that and trying to subsidize or pass laws and find funding that can help people get the care that they need. Because I think one thing that maybe some people don't realize is, also related to that idea that family is very much kind of involved in care, because sometimes these systems with the health insurance programs are, lacking in funding in some ways or, have barriers, families take on a lot of burden when it comes to finances and coordination of care. And so it really does put quite a significant stress on an entire family unit just to care for somebody who has any type of illness, including a mental health illness. And I think particularly sometimes because it causes so much disability, a person with bipolar disorder in the middle of a manic episode, not able to continue their job, their work. And for some people, they need that day-to-day income in order to afford all those costs for treatment. So there's big barriers on a personal level, as well as this higher order level of systems barriers too.
Yeah.
I think there's a lot of programming, from places like the World Health Organization, that it's happening in Ghana that I've heard of, that is really related to, improving access. And again, trying to hit some of those barriers where they're trying to train lots of mental health service providers outside of psychiatrists, because there are only so many people who can go through medical school, through subspecialty, or psychiatry training into subspecialty training. It takes a long time, and sometimes in order to meet people quicker, they need to train other types of health service providers. So caregivers and teachers and police and social welfare officers, all sorts of people that may have kind of a closer, access point in more rural places, have been used as a strategy to try to get people to care and coordinate care for them, as well as get, reduce stigma by just sort of normalizing talking about it. Are you seeing this in some of the more rural places in Nigeria too?
Oh, yes, definitely. So, like one of the things that we also do is, like, during the residency training, we do what we call a community psychiatry program training period, where the residents go into the community, even if it's once a week, work in the primary health settings, and see patients. So patients are pooled, and then they get to see them. They get to, in that process, speak to the nurses, speak to the chiefs in the villages, to explain to them what they are doing and why they are there. And I think that experience for the psychiatrists as well it's eye-opening, because they get to understand how to reach people. And so in doing that, they also get to pass on the knowledge of what psychiatry is to the nurses, to the people in the community, family and caregivers. And so it helps destigmatize mental illness. It helps improve, identification of people with mental health disorders, and hopefully it helps bridge the gap in terms of access to care. Other things that we try to do, in terms of training, even for like training for family physicians, training in medical schools, psychiatry is being put out there as a very important rotation to take. And so it's compulsory for most, for some specialist training to take psychiatry rotations. So that also helps improve the understanding of and the knowledge of mental health disorders. And then we also advocate for, of course, community health workers to get some form of training. So it's more of like looking for the resources to train people. Okay, how do we train people to identify what is a mental health illness? How do we train people on how to refer, where to refer to? Another thing that I know that people do in terms of advocacy is, because countries like Nigeria is very spiritual, very religious, we do a lot of mental health advocacy in churches. So we go to churches and we give mental health talks. We talk about depression, bipolar, substance use. We try to show that, yes, we know that we're not saying that the spiritual angle or the religious angle is not a key factor, but we're saying that, we have a role to play. So these are some of the things that we do. We do it most of the time on our own resources. We do it passionately. We do it because we want to improve healthcare. We go on radio shows. We do what our World Mental Health Days are literally rallies or educating people about mental illnesses, and these are things that we raise money for, and we do and I think we see the outcome, because we see an increase in the number of people that access care. So, and I think for us, that's a good thing. But now it's like, how do we have the resources to care for the people that are seeking care?
Yeah, you made me smirk there, because it reminded me of some of my colleagues who, are in a clinic, doing amazing work every day, seeing a large amount of patients that are showing up, 30, 40 patients in a day, and trying to just get as many people treatment as possible, and then will leave. And before going home to their families, they'll spend a couple of hours going to the local radio station and, doing advocacy and education work on a, weekly basis. And just the amount of, hustle that people within mental health are doing is remarkable. They really are working, in their personal life as advocates just as much as they do in their clinical life as physicians. So I think that definitely translates across many, many different countries, probably, including Ghana. And it's really remarkable to see that. I think if you go into a mental health practice of some kind, you really are, an advocate for life. It is going to be something you have to be passionate about. There's stigma even associated with becoming a psychiatrist. That you have to sort of push through and work through, and people really see it as a life. They're advocates for life, and that's their passion. So I think it's remarkable.
Thank you. Yeah, and I think people I think the energy doesn't stop. Back home, it's not something about, oh, they're tired. People, we just keep pushing. And as much as, yes, I am a psychiatrist, I would also like to commend the mental health nurses, the psychologists, the social workers, the counselors. Everybody goes above and beyond to provide the services that they do for patients or people living with mental illnesses. And when we say advocacy, we don't just stop at, public advocacy. We do it personally. I can only count the number of letters we've written to schools to make sure that people who had a breakdown in school haven't been kicked out of school. To sometimes we write to institutions stating, this, if sometimes we're like, things like, oh, we are watching you, you cannot, because this person has a mental illness, doesn't give you the right to take away their job. So we go above and beyond. We go into their personal lives, to make sure that having this illness doesn't take away from them the life that they should have had more than it will, or, because mental illnesses, we know how difficult it is and the burden it has. So we try to, in our own way, to advocate for our patients, both publicly and privately.
Absolutely. And I think some of the viewers are interested in your passion specifically too, and are asking, you have a research focus here at Michigan Medicine at the Proctor program that was on the role of the family in health outcomes in bipolar disorders specifically. So people are kind of wondering, why is this an area of interest for you? And, why bipolar disorder rather than other things? Kind of how did this passion sort of get started for you?
Okay, so I think it's there from from basically seeing what happens in the clinical setting, how when patients' relatives are fully involved, the outcome seems to be better. So, okay, so is this just a fluke, or does this actually mean something? Because if you notice that for most adults, we don't advocate for family therapy, family intervention. It's usually for children. So, and so that's what, spurred me on to look at this. And then luckily for me, the Proctor program actually had this data, which nobody had looked at. And then, looked at it and realized that, well, it does actually have a positive impact on things like quality of life, which is the first aspect I had looked at. And then subsequently, we'll look at it in terms of readmission rates, compliance and the rest of them. And then back home, of course, I'm going to replicate the exact things now, compare. What's our family structure like? Using like the FACES stood, what's the family cohesion and adaptability like? What's the social support like? How frequent is our undermining behaviors, and how does this affect, patient outcome in the different, or what do you call it, modalities of outcome in terms of quality of life, in terms of patient recovery? And I think that's the ultimate goal, to look at recovery, and because the whole idea is that our aim should be recovery in terms of illnesses. We shouldn't be looking at remission. And for bipolar disorder, most of the time we talk about remission. So we should be moving towards recovery. And so what role does the family play in terms of recovery? Why the family? Why am I not looking at medications? Because, well, medications are what they are. If you increase the dose, you worsen something. If you reduce the dose, you worsen something. So let's look at other aspects that we can actually delve into and make adjustments so that really can improve quality of life without worsening any burden, because medications on their own have the burden. So So these are I'm trying to just wrap it up as fast as I can because I know that we are running out of time. But these are one of the reasons, or these are the reasons why I became passionate about the family, because we've seen that they are very instrumental in patients' recovery, patients' outcome, compliance to treatment, reduction of stigma. Very important. So why don't we study this? And family is something that's universally cultural. Every society has, a role that the family has to play. So it means that universally, whatever we are working on, it can actually be applied to everybody because this is something that, every society holds dear to them.
Definitely. I think that sounds like really important, impactful work for Nigeria as well as many, many other countries. So it's been exciting to talk to you, and I'm sure you will be missed as your fellowship is ending soon. But I'm sure you're also excited to get back to Nigeria with all of the things that you've picked up and worked on here. And I would be remiss if I also didn't mention jollof rice. And
no, you had to see the Ghana in you has come out.
Jollof soon, so I'm jealous for you.
Yes, I can't wait to go home and have my Nigerian jollof, which we know is the best in the world. So.
And I said I have a Ghanaian husband at home, and he's not going to stand for that, so I have to put it for Ghanaian rice as well. It's very nice.
Okay.
Well, thank you so much for speaking with us, Dr. Adiukwu. It's been lovely, and I'm glad that we had you here for the time that we had, and I'm sure our relationships, will continue in the future. Thank you to everybody else for tuning in, and hopefully you learned something interesting today. I know we've also been talking a lot about mental illness and things including suicide. So I just wanted to remind our viewers in the US that you can call or text 988 if there's someone that they know that's in a mental health crisis of any kind. But thank you so much, everyone, for tuning in today.